yet another in an almost endless series of Puscasts, a review of the infectious disease literature, this one covering the last 2 weeks in February in the year 2021. References, as always, are available at edudoc.com, the home of my multimedia empire. And now let's move on to the literature, shall we? As is the new normal, let's start with COVID. A couple of podcasts ago, I mentioned that upon admission with COVID-45, it is unusual to have community-acquired pneumonia complicating, only around 1%. That's not true of ventilator-associated pneumonia. And this study found that the ventilator-associated pneumonias were slightly over twice that of ventilator-associated pneumonias in patients without COVID. As they point out, the increased risk of pneumonia in patients on ventilators secondary to COVID is more than you would expect from just the prolonged duration of their pneumonia. The microbiology was the same as other ventilator-associated pneumonias, with perhaps a wee bit more aspergillus. So early on, don't worry much about secondary pneumonias. Later on, worry a lot. Also an interesting study that showed about 2% of people with COVID get late cavities, not in their teeth, but in their lungs, and this is a poor prognostic sign. Treatment issues. Well, another study that showed the benefit of dexamethasone is predominantly in patients who require oxygen or on a ventilator, and doesn't seem to help people who aren't requiring supplemental oxygen. And again, the best benefit was in those that were sick at least 7 days. And this is to be contrasted with the use of convalescent serum. There were several studies out in the last 2 weeks. One showed that in general, convalescent plasma did nothing. However, another study where it was given within 3 days of onset of symptoms showed mortality benefit. It's very rare in my hospitals to see somebody being admitted with COVID who isn't on like day 8 or 9. Rarely is anybody admitted early in their symptom complex, and those that are admitted earlier often do worse as well as they have more severe disease. I think the general trend for the treatment of COVID so far, with those agents that actually work, is that the earlier the better, but the problem is people are always admitted late with this disease. And while the dumbassitude of the United States in their response to COVID, i.e. the unwillingness to mask and do social distancing and to suggest that these interventions do nothing, is contradicted by yet another study which shows that social distancing works. This study was out of Sweden and looked at social distancing in young adults and found that it slowed the spread of COVID in that population. What a surprise. Infection control actually works. One of the factors that predicts poor outcome in patients with COVID is high levels of interleukin-6, as well in this study as an elevated LDH, procalcitonin, and a low lymphocyte count. To go along with this, there are some studies out this couple weeks that show that patients who receive IL-6 blocking monoclonal antibodies have decreased mortality. The problem with the study is the vast majority of patients did not get glucocorticoids. So what you really want to know is, does an inexpensive and effective drug like dexamethasone have similar outcomes to expensive monoclonal antibodies, and are the two combined even better? That's the problem with many of these studies, that we don't have comparators for outcomes to know what the optimal therapy is for our patients. The best we can say is nothing seems to work real well. There was an unfortunate outbreak, or several outbreaks, of COVID in an English hospital, and the depressing thing was the mortality rate, which was almost 40%, given that everybody in the hospital is probably at high risk for complications for COVID. This is the last place you want to acquire your COVID. Other places for transmission include an interesting study on the effects of being on a train and getting COVID. Not unsurprisingly, sitting next to a COVID patient was a bad idea. And there's a nice review of the risk of the spread of respiratory infections in general in the outdoor versus the indoor. And the take home is you're 18 times less likely to get a respiratory infection outside after exposure than if you're indoors. There's also a nice compare and contrast in emerging infectious diseases on the history of infection control and tuberculosis and comparing it to COVID-45. It makes for a nice compare and contrast. The favorite paradigm for writing essays in college, as I remember it. But the interesting thing is, and I was not aware of this, they discussed an outbreak of tuberculosis on the USS Robert Byrd, and which was interesting because they had one crew member with cavitary tuberculosis and everybody was stuck on the ship, so you could see who was exposed and what the risks were. And here's yet another thing I did not know about tuberculosis. Quote, a particular note, several of the newly infected sailors, indicated by a new positive tuberculin skin test, who were asymptomatic and had negative chest radiographs, were found to have Mycobacterium tuberculosis in their sputum, raising the possibility of transmission with persons without the usual symptoms of TB. Probably old hat to you, but I was always under the impression that no chest x-ray changes equals no tuberculosis, at least transmissible tuberculosis. TB still remains a royal pain in the butt. An unusual manifestation of cytomegalovirus, the pseudotumor. It's a case report on someone with immunosuppression from a MAB who develops a mass in their oral cavity, and it turned out to be due to CMV. Evidently, pseudotumor is a manifestation of CMV. Most of the case reports are in AIDS patients where it predominantly affects the gastrointestinal tract, but there are also a smattering of cases in ostensibly normal hosts as well. So in the family of mycoplasms is a beast that causes prolonged fevers, pancytopenia, and hemolytic anemia in humans. And it is Mycoplasma haemohominis, also referred to as Hemoplasma haemohominis. And there's a description of the first case report of this organism in Australia. There have been other case reports of febrile hemolytic anemia that lasts a long time in human beings. This is predominantly a zoonosis, and it's been found in mice, rats, bats, dogs, monkeys, reptiles, and cats. And evidently, cats get a syndrome of fever and hemolytic anemia as well. The patient was treated with a combination of minocycline and moxifloxacin. I suppose you could call them M&Ms. And the patient did well, doing 4 months of a planned 6-month course of therapy. The particular patient in this study was a wildlife reserve assistant with extensive animal exposure, including bats and marsupials, with a travel history that included wildlife tourism to most continents. So animals, especially wild animals, fevers, hemolytic anemia, pancytopenia, think of Hemoplasma haemohominis. Or what will more likely happen is you'll vaguely remember hearing something about this somewhere and Google fever and hemolytic anemia, and you'll get the hits for Mycoplasma haemohominis. The 2 recommendations for the treatment of chlamydia are either a 1-week course of doxycycline or a single dose of azithromycin. This study compared the effects of those regimens in them with rectal chlamydia as a consequence of men who have sex with men, and found that doxycycline for a week was the superior intervention. So, prosthetic joint infections. 1, a single dose of antibiotic is equal to 3 doses of antibiotic prophylaxis for preventing prosthetic joint infections perioperatively. I have to admit I have this bias, and I really wonder how much systemic antibiotics actually do, since so many of the prophylactic studies are from the era when our adherence to infection control and skip bundles, etc., was absolute garbage. I always suspect that antibiotic prevention is beneficial because you're not doing other infection control interventions appropriately. It's a surrogate intervention for crappy practice. I don't know that, but that still remains my suspicion. I think anytime you're relying on antibiotics to prevent an infection, you're probably doing the wrong thing. The other study looked at the long-term use of quinolones in patients with prosthetic joint infections and found that compared to non-quinolone regimens, there were more toxicities. Big surprise. Tendinopathies, myalgias, arthralgias, and nausea were far more common. Given their toxicities, I tend to avoid quinolones. And again, my bias, as long as you have good source control, it probably doesn't matter what class of antibiotics you choose, and that the, quote, superior killing power, end quote, of quinolones is vastly overrated for most infections once you send the patient home. It's all about the source control, or mostly about the source control. No big surprise, a study out of the VA showed that we're doing a lousy job of treating cellulitis. Patients who didn't need MRSA therapy often got it. People who needed MRSA therapy didn't. I mean, it's pretty straightforward. If you have diffuse erythroderma with no purulence, is probably group A strep, and cephalexin should suffice. If they have a purulent cellulitis, then they need to be covered for MRSA. No one anywhere seems to be able to do that. Again, I've mentioned my speculation about what would happen if we treated cancers with the same lack of rigor that we do with infectious diseases. I don't think anyone would approve. And speaking of MRSA, there was a curious study that showed that MRSA strains are passed back and forth between pigs and humans in North Carolina, just like influenza and other infectious diseases. So these industrial hog operations, as it was called, are a good source for MRSA in humans and in its surrounding communities, and flu and other things. I always remember that the number 2 cause of urinary tract infections in women in their childbearing years is Staph saprophyticus. And I have to admit, I don't think I've ever seen a case in my career, although I don't take care of many outpatient urinary tract infections. And there was a study in the New England Journal a while back that looked at the microbiology of UTIs in that population, and I think they found one case of Staphylococcus saprophyticus. I've always wondered about the legitimacy of that particular microbiologic factoid. This study did find it, but they found a grand total of 299 isolates from humans collected in 7 countries between 1997 and 2017, of which 286 were from UTIs. That's not what you call a huge number of specimens. But the takeaway is this too came from swine, and some strains and lineages of Staph saprophyticus were from pigs and pig farms. And the organism can be found in the gut and rectal flora of livestock, including pigs and cattle, and can be a contaminant of meat and fermented food products. So this is some data to suggest that Staph saprophyticus is actually a foodborne illness. And since it is in the meat processing parts of the world, might be a reason for antibiotic resistance, given the use of antibiotics in livestock production. The sepsis guidelines are all about early antibiotics and giving them quickly when patients come in with sepsis syndromes, preferably within 3 hours. One of the downsides of this particular recommendation is it has kicked up the use of broad-spectrum antibiotics in patients. Quote, SEP 1 implementation was associated with immediate and long-term increases in broad-spectrum hospital-onset MDR organism antibiotics. Is that a good thing or a bad thing? Well, it's going to be a bad thing, and that will likely help long-term drive more antibiotic resistance. The IDSA has evidently taken issue with those recommendations and only wants patients to get prompt antibiotics if they're in sepsis with shock, and not penalize people for taking their time when you have an uncertain diagnosis. And there is an editorial from the IDSA arguing their point. I don't know if I agree. Because in the fog of war, you never know what's going on in patients in the first 24 to 48 hours. And if I had an E. coli doubling every 20 minutes in my bloodstream, I'd like to be killed off sooner rather than later. This is an area of grayness, but I still think, and the vast majority of studies suggest, the sooner the better. Where I quibble with people in the use of antibiotics is not within the first day or two of admission, but continuing those antibiotics long term after you know what's going on. For example, continuing vancomycin when there's no suggestion of MRSA, or treatment with MDRO antibiotics when there is no MDRO isolated. But when patients hit the door and they look septic or septic shock, you got to kill what might kill them until you sort things out. And would have difficulty arguing against the prompt antibiotic administration when you really don't know what's going on up front. You might remember a couple of years back there was a brouhaha about vitamin C, thiamine, and hydrocortisone in patients with sepsis, and that it was the wonder combination that worked wonders. Multiple studies since have failed to back up that initial observation, and there's yet another one in the February 24th JAMA. Basically, the combination doesn't do squat. What a surprise. Maybe if we just added azithromycin and hydroxychloroquine to the cocktail. Never mind. What to do with carbapenem-resistant Enterobacteriaceae? Bunch of articles out suggesting that 1, tigecycline doesn't cut the mustard. 2, we rely on colistin, but its nephrotoxicity rates are remarkably high, around 40%, and it also doesn't seem to do much. There's a couple articles pointing out the superiority of ceftazidime avibactam in the treatment of CRE Enterobacteriaceae, assuming it has the correct mechanism for carbapenem resistance, which is multiple, but that agent, despite its horrific cost, $1,000 a dose or so, it's still superior to colistin and certainly far less toxic. I have been fortunate to have basically no CREs yet in my practice, and I hope in my remaining time that it does not become an issue in my hospitals. What literature there is with CREs suggests that you shouldn't use colistin, try to avoid tigecycline, and if you got the right beast in hand, something like ceftazidime avibactam is the way to go. One of the weird things, though, that happened with that drug when it was released is there was a long time where you could not do susceptibility testing. And I always found that kind of weird. You'd think if an antibiotic was released, you'd also have validated susceptibility testing to go along with it, because that's the only way you're going to know if a drug is actually going to work or not. But I often don't understand these things. Let's move away from pigs for a bit. 1, there was a pet lemur that had MDR-TB, and the poor thing died of tuberculosis. This was an illegally caught lemur that was eventually turned over to a wildlife protective organization in Madagascar, and the hypothesis is that this poor lemur caught tuberculosis from humans, since, as a rule, it's not known that lemurs are carriers of Mycobacterium tuberculosis. Unlike Mycobacterium bovis, which is now found in elephants, free-ranging elephants in Africa, along with rhinos in the area. And of course, M. bovis is a problem with badgers in England, where it serves as a reservoir for infections in cows. And I don't have to prove that because I don't have to show you no stinking badgers. And if you've never seen Treasure of the Sierra Madre and don't know what I was just talking about, you poor thing. But the take home is that M. bovis is widespread in multiple types of large mammals in Africa. And of course, TB can be passed back and forth from humans to elephants. We had an outbreak here at the Oregon Zoo. I mean, just try and imagine 10, 15, 20 milligrams per kilogram of anti-tuberculous medications and trying to give it to an elephant. That is a nightmare. The best test for diagnosing chronic pulmonary aspergillosis, well, that would be the antibody test, specifically the IgG, which in this systematic review and meta-analysis was better and more reliable than precipitins for making the diagnosis. And then the best test for diagnosing pneumocystis is a PCR, not the immunofluorescence assay, in another study published this month. I have had several negative IFAs for pneumocystis in patients who were non-AIDS with the disease and had the disease as a complication of steroids as their only risk factor for pneumocystis. Made the diagnosis on the basis of a beta-D-glucan, and they all got better on Bactrim. Don't trust an IFA in the right circumstance, especially non-AIDS pneumocystis, which I think probably has fewer number of organisms than you see in HIV patients, and so less likely to have a positive IFA, which is short for immunofluorescent antibody. And finally, how long do you treat? Less is increasingly found to be no worse than longer. This study looked at the outcomes of giving people 5-day courses versus longer courses for hospitalized upper respiratory, lower respiratory, and urinary tract infections, and found that going longer than 5 days did not increase the cure rates, but it did increase the complication rates from the antibiotics and the cost. I have long said that we give patients 10 days of antibiotics because we have 10 fingers, and have jokingly said that if I were to lose my hand in a tragic garbage disposal accident, that the courses of antibiotics in the hospital would decrease by half. But currently, given the data, for all infections, we should behave as if we had a tragic garbage disposal accident. And when counting the fingers, just do it on your dominant hand. I would only stick my left hand in a garbage disposal. 5 days is often enough for virtually every infection we want to treat. And that's it. Bring this Puscast to a close, covering the last 2 weeks or so in February in the year 2021. References are available at edgydoc.com, the home of my multimedia empire. And if you have nothing else, then I say, take it away, Jeff.